evening, everybody. I thank Vinita, Dr. Abbas, and the team at Max Care Super Speciality Hospitals for this kind invitation. We've heard very pertinent information from Dr. Sahu, and some of it will be a repeat even in my talk, but I hope it can kind of clarify certain issues because I do agree with what he has said. And let's see the radiation oncologist perspective about the concurrent partner. Just a minute, please. I think something got stuck here. Okay. So we all understand about this disease that we are dealing with. And I think Dr. Neera Gupta started off by saying that this is really our problem. But what we see is that almost 80 to 90% of patients present with local regionally advanced disease. And despite aggressive treatment modalities, the patterns of failure consistently remain local and loco-regional. But thankfully, a lot of these cancers are radiosensitive. The other thing that we need to understand very importantly when we treat head and neck cancers is that while deciding treatment, it is important to consider several patient-related factors, tumor factors, and treatment factors. Now, this is very important, especially in head and neck cancers, because a lot of the patients present with advanced disease, and despite having effective treatment modalities, many of them may not be suitable for these aggressive protocols. And of course, whatever we do, it is essentially a multidisciplinary approach with the patient at the center. Now, the endpoints of interest are also important to consider while considering treatment, and these are essentially related to good disease control and of course, preservation of organ and function. Now, where does radiotherapy come into this? More than 70 to 80% of patients who are treated with curative intent therapy receive radiotherapy as part and parcel of their multimodality approach. It is always an attempt to try and deliver almost about 66 to 70 gray to the gross disease. The microscopic or the high-risk disease sites should receive about 56 to 60 gray, and perhaps the low-risk sites a lower dose of about 45 to 50 gray. Now, the results with radiotherapy alone, I just want you to look at what the radiotherapy alone arms, their local control rates, as well as their overall survival. It's quite clear that they do much poorer as compared to the combined modality treatment arms. And our own experience at the Tata Hospital has also been the same. When we compared conventional radiotherapy to concurrent chemoradiotherapy and accelerated radiotherapy, we realized that patients who received concurrent chemoradiotherapy actually did better than the other two arms. And this is with the 30 milligram per meter square weekly dose, which used to be our practice even till very recently. Now, a word about the mechanisms of radioresistance. This is especially important for us because there are several things that may lead to radioresistance. And if you look at the common chemotherapeutic drugs that are used in the concurrent setting, do contribute in some way to overcome this radioresistance. Hence, we require concurrent chemotherapy to increase the efficacy of radiation therapy, exploit the spatial and temporal effects of concurrent therapy, perhaps to overcome resistance, and query to have some impact on the distant recurrence. Now, what are the various mechanisms that are involved in chemotherapy and radiotherapy interactions? Again, if you look at the various mechanisms that have been proposed, what we need to understand is that a lot of them and a lot of the commonly used drugs are actually a part and contribute in some way to enhancing the effects of radiotherapy. And if you look at our commonest and our most popular drug, that is cisplatin, it actually contributes in some way or the other. So while looking for a concurrent partner, I as a radiation oncologist would look at a partner who could enhance the effect of radiotherapy, defer or obviate radioresistance, acceptable acute and late effects with non-overlapping toxicities, help reduce the dose of radiotherapy for a given endpoint, perhaps reduce the distant metastasis, ultimately enabling us to get good organ and function preservation with an acceptable quality of life in our patients. So what are the options available? I won't go into great detail because Dr. Sahu has already addressed these issues, but a few pertinent points. So we have various cytotoxic chemotherapeutic agents, targeted therapies, immunotherapy, the new kid on the block. And of course, we've heard a lot about hypoxic sensitizers. Now, the commonly used chemotherapeutic agent, as Dr. Sahu has already said, is cisplatinum. Various other agents have been described in literature, and various agents are actually popular among certain institutes. Like if you see the Chicago regime, it's typically with hydroxyurea. If you look at the Gore-Tex regimes, they typically use a combination of 5-FU and carboplatin. So why concurrent cisplatinum? Actually, the story goes long way back, and it started in the early and mid 80s. And there was definite evidence to suggest the efficacy of cisplatinum over certain commonly used agents, especially methotrexate. And today, of course, when we talk about evidence-based management, we have definite evidence from various large-scale phase 3 trials and several meta-analyses. So coming to the first trial that actually set the ground for the use of concurrent therapy, and all of us are familiar with it, this is the RTOG 9111, and it actually taught us that using concurrent chemoradiotherapy could give us the best results when we're talking of organ and function preservation, though of course it did not allude to function preservation. So we had higher larynx preservation, good local regional control. Overall survival rates were, however, similar in all three groups. There was a high grade of toxic effects, especially when we use chemo-based regimes or concomitant treatment modalities. And the other thing, of course, was that mucosal toxicity was very high in the concurrent schedule. These are the various reports of the RTOG 9111, and we can see here that the concurrent radiotherapy arm fared best for local regional control. This is the graph to show the same. For the laryngectomy-free survival, it was again the concurrent chemoradiotherapy arm that did best. But with time, what happened was there seemed to be no difference between the chemotherapy arms. However, if you look at overall survival, there was some amount of concern in the late results with the concurrent chemoradiotherapy as well as the radiotherapy arms. This is a snapshot of the acute and chronic toxicity, which again shows us very clearly that with the use of combined modality management, there is a steep rise in the amount of acute toxicity. However, the chronic toxicities don't seem to be very different between the three arms. Now, of course, cisplatinum is also an agent that has been used in the high-risk adjuvant setting, and all of us are familiar with these two trials from the URTC and the RTOG, which clearly established the role of adjuvant concurrent chemoradiotherapy. Now, of course, coming to the meta-analysis, I won't spend too much time on this because Dr. Sahu has again alluded to the results of this. But clearly speaking, what it did show us was that the definite benefit was from platinum-based chemotherapy, benefit only in the concurrent chemotherapy setting, and monotherapy was better than polytherapy. And this is, of course, a glimpse across the various settings in which chemotherapy was evaluated. Again, about monotherapy, we've seen this forest plot with Dr. Sahu also. Typically, of course, the magnitude of benefit with monotherapy seems to be good. And of course, the 2009 update also kind of reiterated the same thing. And the other important point that it made was that the magnitude of benefit with the concurrent chemotherapy was somewhat lower for patients who were more than 70 years of age. Now, this is a part of the McKinsey that has not been published. Only an abstract has been published, and this was data that was presented at the ICHNO meeting way back in 2017. And what it clearly says that concurrent chemoradiotherapy is good, but it actually threw a few other things into the ring, and that is, of course, the role of induction chemotherapy. And we will soon be seeing a publication from the group which actually talks about accelerated radiotherapy with concurrent chemotherapy, because the original McKinsey meta-analysis actually did not have the taxane-based induction regimes. They did not report on the taxane-based induction regimes. Now, what is the additive effect or the incremental benefit of concurrent chemotherapy, especially cisplatinum? So this is work done by David Brizzle. Essentially, it looked at the RTOG 9003, which evaluated various altered fractionation schedules against conventional radiotherapy. And what they concluded was perhaps that It adds to around 12 gray in 2 gray fraction daily or 1.2 gray twice daily. Of course, there was a paper after this which showed that this was perhaps overrated additive benefit, and they actually put the realistic gain with concurrent chemotherapy at somewhere between 8 to 10 gray. Of course, even considering that benefit, it would be some escalation which would not be possible with adding or increasing the radiation dose alone. So what we know is that concurrent cisplatin, there is definite evidence to use it with radiotherapy, several phase 3 trials, and large meta-analysis. But several unresolved issues remain, and that is essentially with the schedule and dosing of the drug. And of course, as Dr. Sahu has reiterated, the concept of cumulative dose and how to achieve this, especially in the definitive versus the adjuvant settings. The other issue is, of course, in the patient who warrants combined modality treatment, we also have to look at the cisplatin ineligible. And this is, of course, one of the first attempts of looking at it in a randomized manner. Our own work from Dr. Kumar's group at the TMH. And this clearly was a trial that looked at mostly adjuvant treatment in the high-risk patients. Again, what we saw in our data that perhaps in this group of patients, here the dose of cisplatin was 30 milligram per meter square. Perhaps the 3-weekly regime is better than the weekly regime, and local regional controls in the 3-weekly regime were similar with similar progression-free survival and overall survival. Of course, the JCOG 1008 showed something that was completely different. It met its primary endpoint of non-inferiority in survival with the weekly regime. But the difference here was that they use a 40 milligram per meter square weekly regime, and this shows a clear benefit, rather a non-inferiority of the concurrent weekly cisplatin. Again, here the population was adjuvant. The toxicity profile also seemed acceptable. So this was established as the standard of care. We've looked at this. Now coming to the toxicity of cisplatin. Now, these are two papers that have actually looked at defining what we mean by a cisplatin ineligible. As a radiation oncologist, I always worry that if my patient is suitable for organ preservation, but at the same time is not suitable for concurrent cisplatin-based chemotherapy, I need to understand what it is that I have to do for this patient. So this was one of the first papers looking at recommendations for defining platinum unsuitable head and neck cancers. And this is a later, this is one of the papers that has been published very recently in 2019. It has actually addressed most of the issues and has categorized them into relative and absolute contraindications. So what are the options then available for the platinum unsuitable? Other cytotoxic chemotherapy, Dr. Sahu did mention about them. He has also discussed targeted therapies, a little word on immunotherapy, hypoxic sensitizers, and altered fractionation. Carboplat, the main advantage is that it is not as nephrotoxic, neurotoxic, ototoxic, or GI toxic as cisplatin. But of course, the main dose-limiting toxicity is hematologic. This is perhaps the first piece of randomized evidence, though not directly comparing against carboplatin. This trial by Jeremich clearly showed that anything added to radiotherapy is superior to radiotherapy alone, the conventionally fractionated radiotherapy. And if you can see here, the arms that had cisplatin and carboplatin did much better than the radiotherapy alone arm. And this is also for survival. Now, the other thing, of course, comes from our own audit from TMH, 63 patients between January 2011 and 2015. Reasons for patients being unfit for cisplatin. This is very important to look at, and that is low serum creatinine clearance, sensory neural hearing loss in about 28% patients, uncontrolled medical comorbidities in about 5%, and age only in 1 patient. Almost 84% completed the planned treatment. The median CT cycles was 6, and the median OS and progression-free survival was around 28 months as compared to 17 months. And what we have to, the OS and the PFS, and what they noticed was that when you compared it to historical reports of radiotherapy alone studies, the patients who received carboplatin-based CTRT did much better. And these are the tables showing what are the toxicities or the delay reasons for delay in chemotherapy. Mucositis was also acceptable. This is what we see with cisplatinum also. This is another trial from the Gotek group, which has actually looked at combination therapy of carboplatin and 5-FU, which, as I mentioned, is their standard of care with concurrent radiotherapy. And of course, again, it shows clearly that chemotherapy plus radiotherapy is much better than radiotherapy alone. So the main issues, however, with the carbo 5-FU combination is, of course, the 5-FU part of the thing. And we know that in the Indian population, there is a definite problem with infusional 5-FU. And we do know from evidence that we have, especially from the McKenzie meta-analysis, that monotherapy with cisplatinum does quite well, and perhaps equally well, maybe a little bit of difference as much as polychemotherapy. Now, coming to the role of anti-EGFR antibodies, won't go into too much detail, but just the Bonner study, which clearly showed us that radiotherapy versus radiotherapy was cetuximab. The latter did better. However, what we know for sure, and of course, what we have to anticipate as radiation oncologists is the mucositis, the radiation dermatitis, and of course, for the person administering, it is the infusion reactions, which are a matter of concern. Of course, you have later publications from Bonner, which showed clearly that in patients who had the rash, they did much better in patients who did not have the rash. But can cetuximab actually replace cisplatinum? It has been exploited to understand whether we could add cisplatinum and decrease acute and late toxicity, improve compliance to CTRT post-NACT, or can it be used as a method of escalation? So this is the RTOG 1016 in the HPV positive population. All comers were treated, and the conclusions clearly showed that standard of care cisplatinum chemotherapy cannot be replaced by IMRT with cetuximab. The other trial that clearly shows was the de-escalate in the low-risk HPV population. Again here, what was clearly evident was that if you look at the cisplatinum plus RT arm versus the cetuximab plus RT arm, it is quite clear and very obvious that cetuximab cannot replace cisplatinum-based chemotherapy for the primary endpoint, which for their case was actually toxicity. Now, what about bioradiotherapy? This is one of the Trumpo studies, which clearly shows that perhaps there is a place for using cetuximab with radiotherapy in the post-induction phase, but there was no difference in outcomes between the two arms. And in patients who can still receive cisplatinum, I would still continue with cisplatinum, but I would leave it to the judgment of my medical oncologist to see if the patient could consider cisplatinum in the concurrent phase. Now, how about treatment intensification? Dr. Sahu has already spoken about the RTOG 0522, and it clearly says that you cannot add. There is no advantage of adding cetuximab to cisplatinum-based concurrent chemoradiotherapy. The ARTScan 3 also proves the same thing, and this was a multicentric trial conducted out of Sweden. And again, it clearly says that there is no advantage of adding cetuximab for RT when compared to RT plus cisplatinum. Now, the other anti-EGFR agent which we use very commonly is nimotuzumab. It's a humanized form. The first randomized trial, the BEST trial, which was published, 92 patients, again showed some advantage for adding cisplatinum to radiochemotherapy. But of course, this was a 92 patient strong trial. This is our own study, again, that Dr. Sahu has spoken about, 536 patients, and it showed some benefit for adding nimotuzumab to the weekly cisplatinum, which again was 30 milligram per meter square. So we need to understand that and keep that in mind. The other important effect that we need to understand is if you look at the cetuximab trials versus the nimotuzumab trials, there was no increase in the radiation dermatitis. Now, this is a very important thing that I'd like to draw your attention to. Can addition of these anti-EGFR antibodies be used for escalation or intensification of treatment in the HPV negative population? Perhaps this is one of the post-hoc analysis that does generate food for thought, and it does indicate that perhaps in the HPV negative population there may be a role for addition of nimotuzumab to chemotherapy and radiotherapy. So with the anti-EGFR antibodies, definitely today we don't have evidence to replace cisplatinum in the cisplatinum eligible with any of these anti-EGFR antibodies. In the HPV negative population, perhaps there is a rule. And in the post-op NSCT concurrent therapy, we really don't know, but there is this major concern about affordability. Now, taxanes as radiosensitizers, I think both docetaxel as well as paclitaxel have been tried. And we have two ongoing randomized trials at TMH, one with the platinum ineligible, the Dhanush trial, and in the platinum eligible, which is the CVD trial, that is cisplatinum versus docetaxel with concurrent radiotherapy. This is another phase 2 trial, which actually looked at paclitaxel and concurrent radiation. Again, the main concern, of course, was the mucositis. Now, this is a very important part of our radiotherapy armamentarium, the Dahanka study, and the Dahanka 585 protocol clearly showed that there was an advantage to adding this anti-helminthic agent, the nimorozole, to 6 days of radiotherapy. But unfortunately, this is a drug that is not available across the globe. And this is something that has remained confined to the Danish population. The other thing, of course, is the role of altered fractionation radiotherapy, the March meta-analysis, which was published in 2017, which clearly showed that there is a role for altered fractionation radiotherapy. I won't go into the details, but we need to understand that the major advantage of altered fractionation comes with hyperfractionated radiotherapy. And this actually, the only problem with this actually is the fact that this is a logistic nightmare, especially for centers that have a very heavy workload. I won't go to the thing, but the other thing that we need to remember, altered fractionation radiotherapy, like concurrent chemotherapy, is not great in the elderly. And pure acceleration without chemotherapy also does not actually serve any purpose, and this may not be considered. And the logistics are a nightmare. The latest thing that we have, of course, is the addition of concurrent immunotherapy with radiotherapy. The Javelin 100 was presented recently at the ESMO 2020, and it has now, the early results at least show that it is a negative trial. There doesn't seem to be any advantage of adding avelumab. There are various other ongoing concurrent concurrent immunotherapy, radiotherapy trials. What we need to remember very importantly is that today is the age where we have definite evidence to do good radiotherapy, and perhaps that would help us go a long way with the use of these aggressive protocols. We could definitely reduce the toxicity of our treatments. So the take home from me would be, the standard of care is cisplatinum. I really have no doubts in my mind about a patient who is suitable. The patient requires cisplatinum. With relative contraindications to cisplatinum, it could be any of these options. In the patients who have absolute contraindications to cisplatinum, this would be the way I would choose the options. But what is important is that with concurrent chemotherapy, I need to do good radiotherapy and institute appropriate and timely supportive care. This is a table just to show a comparison of the various agents that are available in the concomitant space. And I thank you all for a patient listening, and season's greetings to all of you. Thank you.
Yeah, thank you, ma'am. Thank you for a wonderful presentation. And I think we move to the next session, and I think we move to the next question first. Next question, please. Can you display the question number 2? And the question is, in cisplatin eligible locally advanced squamous cell head and neck patients, chemoradiation plus nimotuzumab is the best treatment option than RT plus other targeted therapies. A answer is yes if you agree. If you don't agree, answer is no. That's the B option, and C is not sure. It's better, yeah. Nimotuzumab, CRT plus nimotuzumab is a better treatment option than RT plus other targeted therapies. That's the question. And we are.
The poll is started, sir.
Yeah. Okay. Great. So 72% do consider that in cisplatin eligible locally advanced head and neck cancer, CRT plus nimbutuzumab is a better treatment option. And 22% say no, and I think 5% are not sure. And that's how it's poised